Pediatric neuroblastoma is a malignant tumour that accounts for around 8% of all childhood cancers. It has a median age at diagnosis of 18 months, with 25 to 50 cases per million individuals diagnosed each year. Approximately 50% of these children will have metastatic disease at diagnosis. While the direct causes of neuroblastoma are unclear, it is known to originate from a mutation during the embryonic development of the peripheral nervous system. Usually, neural crest cells migrate throughout the embryo and go on to form multiple different tissues, including the sympathetic nervous system. The normal development and differentiation of neural crest cells into multipotent cells via neuroblasts is a complex process regulated by the expression of multiple genes. During this development, mutations can take place in these neural crest cells, which are likely to be the origin of neuroblastoma. Once present, neuroblastomas are difficult for the body's immune system to target, due in part to lower receptor expression of MHC1, DNAM1, and NKG2D. The lack of MHC1 receptors helps to camouflage these neuroblastoma cells from T cells, meaning new and innovative targets must be developed in order to treat these patients. Dinutuximab beta combats high-risk neuroblastoma by targeting a complex glycolipid known as the GD2 ganglioside, found on the plasma membrane of tumour cells. While GD2 is only weakly expressed in normal brain tissue, it is abundantly expressed in neuroblastoma cells. This makes it an ideal target for immunotherapy. Dinutuximab beta is a mouse-human chimeric monoclonal antibody. It consists of the variable regions of mouse antibodies, combined with the constant region of human antibodies. This means that the antibody can provoke an immune response without losing its ability to bind to GD2 and to key cells of the human immune system. By binding to GD2 on the surface of neuroblastoma cells, dinutuximab beta can bypass the camouflage neuroblastoma cells would normally have. Due to dinutuximab beta's human murine structure, the body's immune response is now able to recognize the tumor cells and destroy them. Dinutuximab beta harnesses the immune system in ways that are both adaptive and innate. The adaptive mechanism uses antibody-dependent cell-mediated cytotoxicity, or ADCC, while the innate mechanism uses complement-mediated cytotoxicity, or CMC. ADCC occurs when granulocytes and natural killer cells recognize and engage with the dinutuximab beta that is bound to neuroblastoma cells. After engaging, the granulocytes and natural killer cells release cytotoxic granules and cytokines which kill the tumor cells. CMC occurs due to the binding of the protein complex C1q to the tumor-bound dinutuximab beta. This activates the complement cascade, which is part of the innate immune system that enhances the activity of antibodies and phagocytic cells. This, in turn, causes the formation of membrane attack complexes, which create pores in the targeted cell membrane, leading to cell lysis and death. One of the most common adverse events is pain, while immunotherapy-related pain has been seen in up to a quarter of patients. However, this typically happens during the first infusion of dinutuximab beta and decreases over subsequent treatment cycles. Other side effects include pyrexia, hypersensitivity, vomiting, diarrhea, capillary leak syndrome, and hypotension. Dinutuximab beta's targeted mechanism of action can allow you to give your high-risk neuroblastoma patients the specificity they deserve.